I'm Professor Wu from Beijing General Hospital, and today we will talk a terrible thing in the case um, about the tamponade or perforation. I think it's a terrible thing for almost all the cardiologists. This is a 12-year of scar registry from 2005 to 2017. There was total almost 243,000 PCI patients. Among them, about 1,008 cases identified perforation. During the time of period, the study, the incidence of perforation, you can see that the rate was almost constant. Although the procedure complexity and the number of the procedure increased, if the procedure or if the perforation happened, the prognosis become worse as expected. The green one, you can see that the green one indicate MACE rate without perforation or tamponade, and the red one indicate any perforation or tamponade. So most event occurs in the first year. You can see in the first year after procedure, not only the curve for the MACE, also in the TLR and the mortality, and other catch-up sign for the standard stenosis or thrombus is well defined. Significant associations of increased risk of perforation include higher age, female sex, previous smoker CTO lesion, and B2-3 lesion, direct standing road bladder, and unsuccessful wire attempt. So it's worth noting that the proportion of CTO portion is only quarter of the total lesion, but nearly 80% is B2 and 3 lesions, mainly because of their control difficulty in calcified lesion, tortuous lesion, and bifurcation lesion. The registration study also found that the perforation resulted in tamponade in 36%, and of those, acute tamponade occurs in 15% and late tamponade in 21%. Most perforation did not lead to acute tamponade, which may demonstrate the skill of the operator who were able to avoid the development into such a serious complication. In such cases, mortality and other MACE rate were slightly elevated in the initial phase, but the reassuring soon passed the event curve for non-perforation. The SCAR registry also found that the late tamponade was surprisingly serious, as mortality rate throughout the study period almost as high as the acute tamponade, and significantly higher than that of the perforation without tamponade. The results are serious, considering that the cause of the perforation of late tamponade is often a guide wire penetration in small vessel or in the distal or the side branch. The majority of the cases were not recognized during the procedure at the prime time. Once perforation recognized, a severe important step should be undertaken to prevent progressive extravasation and allow institution of measure to identify treat the perforation. So the first and important thing is to obtain additional staff to assist it is desirable. The second thing is inflation compliant ball placed proximal to the site of perforation at low pressure with limit extravasation and allow for technique designed for definitely treat the perforation site. Once the extravasation is limited by balloon inflation, definite treatment can be performed, such as prolonged balloon inflation may allow small perforation to seal without additional intervention. But in that time, reversal of the heparin in this setting should be avoided if possible, as it may predispose to stent thrombosis and you can see the case. This is a diffused lesion circ case. No obvious calcification, and I use a balloon to predilate. I think the result is acceptable. After that, no Evans check. The stent size seemed a little bit larger, so the perforation happened. You can see that. I guess type 2 or 3, I'm not sure at that time. However, I use a 2.5 balloon to sealing as the proximal site of the perforation for 20 minutes, and meanwhile, I prepared cover stent. Lucky enough, the extravasation stopped, so I firmly believe it may be X type 2, not type 3. In the event if the perforation ongoing, treatment option will develop on procedure and vessel characteristics. Large caliber vessel may be treated with cover stent, and if the perforation is small, I can use the microcatheter to deliver the coil to the fat or the gelatin sponge or the surgical suture to the distal of the vessel to stop the hemorrhage. Although perforation and the tamponade cannot be avoided completely, but something we could pay more attention to reduce the incidence of the such worse thing. Quite a few perforation cases will be avoided performing bilateral injection. You can see that. I don't think it's a difficult CTO case because the CTO occluded length so short and the collateral can get so high level. Can see that? Can get here. So the occlusion length is not so long. But the operator firmly believed the proximal cap located here. So he used the stiffer wire to penetrate, he believed, the cap. But I think the proximal cap may be located here. So the big vessel is diagonal, not LAD. Without the control injection, use a balloon predilate. So without doubt, the tamponade and the perforation happened. Can see. So when you're facing a situation with ambiguous type, though, even if a little doubt, don't hesitate to perform control injection. It's so important. This is another LAD situation with ambiguous cap. The occluded length also not very long, but it's the most difficult thing is the wire is easily slip to the big diagonal, not in the LAD vessel structure. So the operator used the side-base technique. Can see, use the side-base technique and use the wire knuckle to the vessel structure. But I think the knuckle wire is maybe not in the vessel structure. Even if in the vessel structure is so close to the outer member, not close to the tunic medium. From these both two projections, all the wire seemed in not set in an unsatisfied location. It's too far. Then the stingray balloon in position, but the gap to the true lumen was so far. Although perforation was not emerging in the first procedure at the prime time, but the terrible things was predestinated. Just 1 hour, the patient back to CCU, blood pressure down to 60/30, heart rate over 130 after the pericardial drainage, obvious obvious. Yeah, you can see perforation. Yeah, you can see here. So the patient back to the catheter lab, but we also did not find the repeat angiograph did not find the obvious perforation. So after the drainage, the patient sent to the emergency bypass on the safe side. So when you're facing the difficult proximal cap, special techniques such as side base, scratch and go could contribute the wire into the vessel structure. But if the wire is far from the tunica medium, close to adventitia, so you can use also it be dangerous. You can use a parallel wire technique. Stay the first wire in the here and make the second wire close to the tunica medium, and you can perform the ADR or RDR subsequently. I think it can be more safer. It was tortuous combined with calcification, circ lesion. Can see the target lesion is abused marginal. Very tortuous, severe calcification. The guiding catheter could give much more support, but in small vessel, it could be dangerous. Can remember, if the vessel diameter smaller than 2 millimeter, it's dangerous to use a guiding catheter. The perforation just happened at the site of the acute bending. You can see here, at the acute bending. Balloon dilation at the prime time, and the operator did not take the picture. After 30 minutes sealing, the extravasation stopped. So I think the operator is lucky enough. Only left encapsulated infusion. So did not lead to tamponade. It's another circ case. The same calcification and the similar tortures is a post-cabbage patient. The small balloon cannot cross it, so I performed the prime root ablation using the smallest burr, 1 to 5 burr, and for 3 times, can see, it's a Q bend here. And after that, we noticed that the perforation happened at the bending, also at the bending, but not induced tamponade. So I think the circ, especially, So the circ lesion, especially the tortuous and the calcified circ lesion, is a perforation high-risk patient lesion. Once you decided to perform the circ lesion, just like these two cases, pay more attention and could make full preparation before the procedure. So this is regrettable cases. Can see that left main true bifurcation, and the operator placed 3 wire to the LAD, to the Ramers, and to the circ, and performed the DK crush technique. I think the result is acceptable. But the blood pressure decreased after the procedure, little by little. Repeat angiograph, we can see the perforation at the distal of the Ramers. After pericardial drainage, the blood pressure arises. The operator believed the perforation stopped, so he did not deliver any coil or any other things to the distal wire to block the hemorrhage. But the blood pressure down again at that night and induced the thrombus. So if you, as you concentrate the target lesion, especially to the proximal target lesion, pay more attention to the distal wire or the side branch wire. Hold firmly the wire, especially when you withdraw the long device Once perforation happened, do not underestimate the potential risk. Do what you can do to deal with the perforation at the prime time. Take chance is not good for these cases. It's a similar case, LAD CTO lesion, and I perform the retrograde to open the CTO lesion, and I use a wire to protect the diagonal. But after the procedure, I found the perforation at the distal of the diagonal. You can see here and here. At that time, the patient only felt slightly discomfort, and the blood pressure and heart rate is normal. The coil was delivered to the diagonal via fan cross microcatheter to seal the perforation, and the echo only showed limited pericardial infusion. So according to the statistic result, the perforation and the tamponade could not be totally occluded as PCI volume increased and more complex lesion coming up. However, we could understand what is the high-risk patient and what is the high-risk lesion, and meanwhile make full preparation, and the backup plan or support may be reasonable for us all. Thank you.